Ever wondered why some childhood bugs seem to, spread like wildfire, while others just fizzle out?
Yeah, it's a really fascinating interplay between microbes and our immune systems.
Welcome to the Deep Dive. We're here to unpack complex health topics. Today we're tackling infectious and communicable diseases, drawing heavily from the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
Our goal here is really to give you a clear, thorough grasp of this whole area. Think of it as like a fast track to understanding the key nursing concepts, how to assess things, safety stuff, and what interventions actually work.
Exactly. And we'll also cover some critical ground on HIV and AIDS in children, plus the basics of immunizations. We want to make all this info understandable, maybe even memorable.
Right. We'll define the medical terms as we go, so don't worry about getting lost in jargon.
Perfect. We're basically pulling out the essential knowledge you'd get from that detailed review, making it accessible. Okay, let's dive in. First up, a big one. Human immunodeficiency virus, or HIV, and acquired immunodeficiency syndrome, AIDS.
Okay, so AIDS. It's a disorder caused by HIV, the human immunodeficiency virus, and it really hammers the immune system. Our source actually has a figure, FIF 901, that shows this visually, though we can't see it here.
Right.
What's key is that an AIDS diagnosis isn't just about having HIV. It's actually linked to having specific opportunistic illnesses or conditions, things that take advantage of that weakened immunity. Box 37-1 in the text lists these out.
And how does HIV actually weaken the immune system like that?
Well, its main target is a type of white blood cell called the CD4 plus T cell. These cells are absolutely crucial for a healthy immune response. HIV gets into these cells, multiplies, and gradually kills them off. So the number of CD4 plus T cells goes down.
Oh, links to power on.
Progressive immunodeficiency. Basically, the immune system gets weaker and weaker, making the person vulnerable to those opportunistic infections we mentioned, like pneumocystis jiroveci pneumonia, which Bach 37.1 also gives as an example.
So how does this virus actually spread? That's crucial.
Absolutely. It's transmitted through contact with specific body fluids. Blood, semen, vaginal secretions, and breast milk. And the incubation period, the time from infection to symptoms showing up, it can be really long, months, sometimes even years.
Wow.
Now, transmission routes. There are basically two main ways. Horizontal transmission, that's person to person, usually through intimate sexual contact or what we call parenteral exposure.
Parenteral meaning, like not through the mouth.
Exactly, like sharing needles or a needle stick injury. Getting infected fluids directly into the body, bypassing the digestive tract. Then there's vertical or perinatal transmission. That's from an HIV-infected mother to her baby during pregnancy, birth, or breastfeeding. Chapter 23 in the source goes into more detail there.
And you mentioned pneumocystis jiroveci pneumonia earlier. Is that a particular concern for children?
Very much so. It's actually the most common opportunistic infection in HIV-infected kids, especially hitting those between 3 and 6 months old. It really underscores how vulnerable these infants are.
So for anyone caring for a child with HIV, the big takeaway is?
The risk of life-threatening infections is significant. Constant vigilance is key. You need to monitor super closely for any sign of infection and report it immediately. Boxes 3701 and 3702 in Saunders give a lot of detail on what signs and symptoms to look for the data collection part.
Okay. And if HIV is suspected, how does the diagnostic process start?
Well, testing is obviously a big step, so pretest counseling for the parents is really, really important.
What does that involve?
It means talking through what HIV is, why the test is being recommended, what a positive result might mean, confidentiality huge, and importantly, the benefits of catching it early and starting treatment. Table 37.1 in the source lists the different diagnostic tests available.
Right. So let's say a child is diagnosed. What does the ongoing care involve?
It really takes a village. You need an interprofessional team, doctors, nurses, social workers, specialists. The main goals are, first, to slow down the virus replicating. Second, prevent those opportunistic infections. Third, provide good nutritional support. Fourth, manage any symptoms the child has. And fifth, treat any opportunistic infections that do pop up.
I see. The source mentioned something called prophylaxis. What's that about?
Prophylaxis just means preventative treatment. So for kids exposed to or infected with HIV, we give them medicine to prevent certain infections, especially that pneumocystis pneumonia. This is super critical in the first year for babies born to moms with HIV.
And after the first year?
After age 1, whether they need to keep taking it depends on how suppressed their immune system is or if they've already had pneumocystis pneumonia. It's really guided by their overall HIV status, history, and those CD4 plus counts, which tell us how the immune system is doing.
Makes sense. Then there are the antiretroviral medications themselves. These are key.
Absolutely central. But before giving any antiretroviral med to a child, you must verify it's safe for kids, the right dose, check for contraindications, reasons not to give it, and know the potential side effects. Chapter 60 in Saunders covers these meds in detail.
And the goal of these drugs.
The main goal is to suppress HIV replication, stop the virus from making copies of itself. By doing that, we slow down the loss of CD4 plus cells, preserve immune function, cut down on opportunistic infections, and delay the disease progressing to AIDS.
How do they actually work?
It's pretty clever, actually. Different drugs target different steps in the virus's life cycle. Some stop it from entering cells, others stop it from copying its genetic material. By hitting multiple stages, they reduce the amount of virus produced. That's why combination therapy using several different antiretrovirals together is the standard. It makes it much harder for the virus to develop resistance.
Okay. What about regular childhood shots, vaccinations? Are those safe for kids with HIV?
Generally, yes. Routine immunizations are usually recommended for kids exposed to or infected with HIV. However, there are some really important exceptions, especially if the child has symptoms of HIV or severe immunosuppression.
Like what?
For those kids, you only use the inactivated intramuscular flu vaccine each year. No live virus vaccines. So the measles vaccine is out. They might get immunoglobulin after exposure instead.
Okay.
Same for polio, only the inactivated shot. Rotavirus vaccine is contraindicated. Varicella, the chickenpox vaccine, also contraindicated. Again, they might get varicella zoster immunoglobulin after exposure. And for tetanus-prone wounds, they might need tetanus immunoglobulin.
Those distinctions are crucial. Now, shifting to home care, what do parents or caregivers absolutely need to know?
Oh, there's a lot, but it's all vital. First, hand washing. Everyone in the house. Frequently, it's basic, but so important.
Right.
Caregivers need to be hawk-eyed for signs of illness. Fever, malaise, just feeling generally unwell, fatigue, weight loss, vomiting, diarrhea, changes in activity, sores in the mouth. Report any of that to the healthcare provider right away. Be alert for signs of opportunistic infections, like a cough that won't quit, could be pneumonia. Medications must be given exactly as prescribed, right dose, right time. Avoid contact with anyone who's sick. Keep immunizations up to date, following those specific guidelines we just talked about.
Okay.
Keep the child home when they're sick. Avoid unprotected contact with body fluids. Monitor weight regularly. Nutrition is key. Aim for a high-calorie, high-protein diet. Maybe use appetite stimulants if the doctor prescribes them.
And practical things, like utensils.
Never share utensils. Wash them in a dishwasher. Handle food and formula properly. Cover, refrigerate, discard after 24 hours. If the immune system is really weak, the doctor might suggest a neutropenic diet, avoiding fresh fruits, veggies, raw meat, or fish. Always wear gloves for care involving body fluids, especially diaper changes. Change diapers often, away from food areas. Seal soiled diapers in a plastic bag. Dispose of them in a covered bin. Take trash out daily. And clean up any body fluid spills immediately with a bleach solution, usually 10 parts water to 1 part bleach.
That's a very thorough list.
Yeah.
What about teenagers living with HIV? What's important for them?
Education is key there. Need to have frank discussions about high-risk behaviors, unprotected sex, sharing needles, and stress avoiding them. They need to understand all the ways HIV is transmitted.
Right.
Abstinence is the safest option, but if they are sexually active, consistent and correct condom use is non-negotiable. And importantly, make sure they know about available support resources, medical care, counseling, peer groups. They need that support system.
Okay, that covers HIV and AIDS really well. Let's shift gears now to some specific infectious and communicable diseases. Saunders goes through quite a list, from rubeola through Rocky Mountain spotted fever. For each, we need to understand the basics: the agent, incubation when it's contagious, the source, how it spreads. Let's start with rubeola, or measles, as most people know it.
Right, rubeola or measles, caused by the paramyxovirus. Incubation is typically 10 to 20 days, and it's contagious for quite a while, from about 4 days before the rash shows up until 5 days after it appears. Most contagious early on in what's called the prodromal stage.
And it spreads how?
The virus is in respiratory secretions, blood, urine, so it spreads through airborne particles, coughing, sneezing, direct contact with droplets, or even transplacentally from mom to fetus. Some key terms here. Coryza, basically a runny nose. Erythematous just means red. Maculopapular describes the rash, flat spots, and raised bumps. Desquamation is skin peeling, and complex spots, we'll get to those. Figure 37:1 in the book shows the typical measles rash.
So what classic signs and symptoms point towards measles?
You'd look for fever, feeling generally unwell, malaise, then the classic 3 Cs, coryza, runny nose, cough, and conjunctivitis, red, watery eyes.
Okay.
The rash itself is red, that maculopapular type, usually starts on the face, spreads down the body. If you press on it, it blanches, turns white temporarily, then it turns brownish and lasts about a week. Skin peeling, desquamation might happen as it fades.
And those complex spots?
Ah, yes, very distinctive. They're small red spots with bluish-white center, usually inside the cheeks on the buccal mucosa. They typically show up before the main rash and last about 3 days.
Got it. So nursing interventions for measles.
If hospitalized, airborne precautions are a must. Keep things quiet, encourage rest. A cool mist vaporizer can help the cough and runny nose. Dim the lights, as kids with measles are often sensitive to light photophobia. And antipyretics, fever reducers, as needed.
Okay, next up, roseola, also called exanthema zubitum or sixth disease.
Roseola, caused by human herpes virus type 6. Incubation is about 5 to 15 days. When it's contagious isn't totally clear, but probably from when the fever starts until the rash appears. How it spreads isn't fully understood either. Figure 37:2 shows the rash.
What are the key signs for roseola?
The big hallmark is a sudden high fever, often over 102 degrees air, that lasts 3 to 5 days, but the child often seems relatively okay otherwise.
Interesting.
Then, boom, the fever breaks, and then the rash appears. It's usually rose-pink, flat spots, macules that blanch when you press them. Shows up a few hours to maybe 2 days after the fever's gone and lasts only a day or two.
And management.
Mostly supportive. Keep the child comfortable. Manage the fever with antipyretics. Make sure they drink fluids. The rash itself usually isn't bothersome.
All right, let's talk rubella German measles for 3-day measles.
Rubella, caused by the rubella virus. Incubation, 14 to 21 days. Communicable period starts about a week before the rash and lasts about 5 days after it appears.
Where's the virus found?
Nasopharyngeal secretions, nose and throat fluids, but also potentially blood, stool, urine. Spreads via airborne droplets, direct contact, contaminated objects, and also transplacentally, which is a huge concern. Figure 37:3 shows the rash. Oh, and petechiae, tiny pinpoint red spots from bleeding under the skin, can sometimes be seen.
What signs suggest rubella?
Usually a low-grade fever, feeling unwell. The rash is typically pinkish red, maculopapular, starts on the face, and spreads really quickly over the whole body in 1 to 3 days. Unlike measles, it often disappears in the same order it appeared.
Anything else distinctive?
You might see petechiae on the soft palate, sometimes called Forsheimer spots. And swollen lymph nodes are common, especially behind the ears and at the back of the neck.
Nursing interventions for rubella.
If hospitalized, airborne and droplet precautions. Supportive care for symptoms. Critically, though, you must isolate infected kids from pregnant women because of the severe risk of birth defects congenital rubella syndrome if a woman gets infected during pregnancy.
Very important point. Okay, next. Mumps or epidemic parotitis.
Mumps, another paramyxovirus. Incubation, 14 to 21 days. Contagious from just before the glands start swelling until after the swelling goes down.
Spreads how?
The virus is in saliva, sometimes urine. So direct contact with saliva or droplets spread from coughs and sneezes. Key terms: parotid, the salivary gland near the ear that swells up, and orchitis, inflammation of the testes, a potential complication in males.
What are the signs and symptoms to look for?
Often starts with fever, headache, feeling unwell, maybe loss of appetite. Then the classic sign: jaw or ear pain, worse with chewing, followed by that noticeable swelling of one or both parotid glands.
All right, the chipmunk cheeks.
Exactly. Orchitis, testicular pain and swelling can happen, especially after puberty. And rarely, aseptic meningitis, inflammation around the brain and spinal cord.
How do you care for a child with mumps?
Airborne and droplet precautions. Bed rest until the parotid swelling is down. Soft foods are easier to manage than things requiring lots of chewing. Hot or cold compresses on the neck might help. For orchitis, warmth and support like snug underwear can provide relief. And keep a close eye out for signs of meningitis.
Moving on to varicella, good old chickenpox.
Chickenpox, caused by the varicella zoster virus. Incubation, 13 to 17 days. Communicable period is from 1 to 2 days before the rash until all the spots have crusted over, usually about 6 days after the first spots appear.
Where's the virus? How does it spread?
It's in respiratory secretions and the fluid in the skin lesions, the vesicles. Spreads by direct contact with those lesions, airborne droplets, or touching contaminated items. Figure 37:4 shows how the rash progresses. Vesicles are those small fluid-filled blisters. Pustules are when they fill with pus.
What are the telltale signs?
Usually starts with a slight fever, feeling unwell, maybe not hungry. Then the rash. Starts as small red spots, nacules, often on the trunk, and scalp first, then spreads. These quickly turn into vesicles, then pustules, then they dry and crust over.
Yeah.
Lesions can also pop up inside the mouth, genital area, rectum. A key thing about chickenpox is the rash comes in waves or crops. So you'll see spots in all different stages, macules, papules, vesicles, pustules, crusts, all at the same time.
How is it managed, especially regarding spread?
In the hospital, strict isolation, contact, and airborne precautions. At home, isolate until all lesions are crusted. The antiviral acyclovir might be used, especially for immunocompromised kids or severe cases. For high-risk kids exposed to it, varicella zoster immune globulin might be given. Nursing care is supportive. Rest, keep cool. Things to relieve itching like calamine lotion or antihistamines if prescribed. And absolutely isolate high-risk kids like newborns or those with weak immune systems from anyone with chickenpox.
Okay, next disease. Pertussis, or whooping cough.
Pertussis. Caused by a bacterium, Bordetella pertussis. Incubation. 5 to 21 days, average about 10. It's most contagious early on, during the catarrhal stage, when it just looks like a cold.
Source and spread.
It's in respiratory discharge, spreads by direct contact, droplets from cough, sneezes, or touching contaminated things.
What are the classic symptoms?
Starts like a regular cold runny nose, mild fever, mild cough, but then it progresses to that severe cough characterized by paroxysms. These sudden, violent coughing fits often followed by that high-pitched whoop sound when they try to breathe in.
That sounds awful.
It is. Infants especially can get cyanosis, turn blue around the lips, have trouble breathing, tongue might stick out. They can be listless, irritable, lose their appetite.
How is pertussis treated?
Isolation is key, especially early on. If hospitalized, use airborne droplet and contact precautions. Antibiotics, like azithromycin, are given to kill the bacteria, but they work best if started early.
And nursing care.
Try to reduce triggers for coughing spasms, dust, smoke, sudden changes in air. Keep them hydrated and nourished, maybe small, frequent feedings. Suctioning and humidified oxygen might be needed, especially for babies. Monitor their breathing and oxygen levels closely. And importantly, remember, babies don't get immunity from mom, which is why Tdap vaccination for adults around infants is so critical, that cocooning strategy.
Right. Okay, let's talk about diphtheria. Thankfully, much rarer now due to vaccines.
Diphtheria. Caused by Corynebacterium diphtheria. Incubation is short, 2 to 5 days. How long it's contagious varies, but basically until tests show the bacteria are gone from secretions, which can take weeks, even with treatment.
Source and spread.
Discharge from the nose, throat, skin lesions of an infected person or carrier. Spreads by direct contact or touching contaminated items. Key terms. Pseudomembrane, that thick, grayish membrane in the throat that can block breathing. And lymphadenitis, swollen neck, lymph nodes, leading to that classic bull neck look.
What are the signs?
Low-grade fever, feeling unwell, sore throat. A foul-smelling, thick nasal discharge is characteristic. That pseudomembrane in the throat is the hallmark. It can make eating, drinking, breathing very difficult. And the swollen neck nodes, the bull neck appearance. Toxins can also affect the heart and nerves in severe cases.
Management in hospital.
Strict isolation, contact, and droplet precautions. The main treatment is diphtheria antitoxin to neutralize the bacterial toxins, usually giving right away if diphtheria is suspected. Bed rest is important. Antibiotics, like penicillin, are also given.
What about breathing support?
Suctioning humidified oxygen may be needed. If the airway is severely blocked by that membrane, a tracheostomy, a surgical opening in the windpipe, might be necessary. Close monitoring of breathing and heart status is critical.
Okay, next. Poliomyelitis, or polio. Another one largely controlled by vaccines.
Polio, caused by enteroviruses. Incubation is usually 7 to 14 days. When it's contagious isn't precisely known, but the virus is in the throat and feces shortly after infection. Stays in the throat about a week, but can be shed in feces for 4 to 6 weeks.
How does it spread?
Found in oral secretions and feces. So, direct contact, fecal-oral route, ingesting contaminated particles, and oropharyngeal route, saliva droplets. Key term: flaccid paralysis weak, limp muscles with loss of tone.
What are the symptoms?
Can start non-specifically. Fever, feeling unwell, poor appetite, nausea, headache, sore throat, maybe abdominal pain, then soreness and stiffness in the trunk, neck, limbs. In some cases, sadly, it affects the central nervous system, causing muscle weakness and potentially that flaccid paralysis, which might be temporary or permanent. It can affect breathing muscles, too.
How is polio managed?
Enteric and contact precautions are crucial to prevent spread, especially fecal oral. Treatment is supportive, no specific antiviral. Bed rest during the acute phase. Nurses need to monitor very closely for respiratory paralysis, which is life-threatening. Physical therapy is vital for recovery and rehab. Pain management, too.
All right, let's move to scarlet fever.
Scarlet fever. Caused by group A, strep bacteria, same ones that cause strep throat. Short incubation, 1 to 7 days. Communicable period is about 10 days during incubation and illness, plus potentially during the carrier stage.
Source and spread.
Nasal and pharyngeal secretions from an infected person or carrier. Spreads by direct contact, droplets, or touching contaminated items, sometimes contaminated food milk. Figure 37 to 5 shows some signs. Key terms: desquamation, skin peeling, positious sign, those red lines and skin creases, and strawberry tongue.
What are the classic signs?
Sudden high fever, flushed cheeks, vomiting, headache, swollen neck nodes, feeling unwell, maybe abdominal pain. Then the rash.
Yeah.
Red, fine, feels like sandpaper. Starts in armpits, groin, neck, then spreads, usually sparing the face. It blanches on pressure, except in those skin creases where you see bright red lines. That's positive sign. Desquamation, that sheet-like peeling, especially on palms and soles, happens later, maybe 1 to 3 weeks after onset.
And the strawberry tongue.
Right. Initially, the tongue might have a white coating with red bumps sticking through white strawberry tongue. Then the white peels off, leaving a bright red, swollen tongue with prominent bumps, red strawberry tongue. Tonsils are usually red, swollen, maybe have exudate. Throat looks beefy red.
Nursing management.
Contact and respiratory precautions until I've had 24 hours of antibiotics. Supportive care, bed rest, encourage fluids. Finishing the full course of antibiotics is critical to prevent complications like rheumatic fever or kidney issues.
Okay. Next is erythema infectiosum, fifth disease, or slap cheek syndrome.
Fifth disease, caused by human parvovirus B19. Incubation is usually 4 to 14 days, maybe up to 20. Contagious period is thought to be before the rash appears. Once the rash is there, they're generally not contagious anymore.
How does it spread?
Believed to spread through respiratory secretions and blood. Figure 37-6 shows that classic slap cheek look.
What are the typical signs?
Before the rash, maybe mild flu-like symptoms or nothing. Then the rash comes in 3 stages. First, that bright red rash on the cheeks, the slapped look, lasts 1 to 4 days.
Stage 2.
About a day later, a maculopapular red rash appears on the arms and legs, spreading outwards. Often looks lacy or net-like, can last a week or more.
And stage 3?
The rash might fade, but then reappear if the skin gets irritated by sun, heat, cold, exercise, friction.
How is it managed?
Usually doesn't need hospitalization. But pregnant women should avoid contact due to risks to the fetus. Management is supportive fever reducers, pain relievers if needed. Anti-inflammatories might be used. The rash usually isn't itchy.
Moving on. Infectious mononucleosis, mono, or the kissing disease.
Mono, caused by Epstein-Barr virus, EBV. Long incubation, 4 to 6 weeks. How long it's contagious isn't exact, but likely for some time after symptoms fade.
How does it spread?
Primarily through saliva, hence the nickname. Key terms: hepatosplenomegaly, enlarged liver and spleen, lymphadenopathy, enlarged lymph nodes.
What signs point to mono?
Fever, severe sore throat, feeling really unwell, headache, fatigue, nausea, maybe abdominal pain. On exam, enlarged red tonsils, often with white patches. Swollen lymph nodes, especially in the neck, are classic. Enlarged liver and spleen are common. Sometimes a faint rash, especially if given certain antibiotics like ampicillin.
How is mono managed?
Mostly supportive. Rest is crucial because fatigue can last a long time. Fever pain relief with acetaminophen or ibuprofen. A key nursing role is monitoring for splenic rupture, a rare but serious complication.
What are the signs of that?
Sudden, severe abdominal pain, especially upper left side, maybe radiating to the left shoulder. Parents need to know these signs and avoid contact sports until the spleen is back to normal size, confirmed by a doctor.
Okay, last one in this group. Rocky Mountain spotted fever.
Rocky Mountain spotted fever, RMSF, caused by a bacterium, Rickettsia rickettsii, incubation, 2 to 14 days. Source is an infected tick, usually one that fed on rodents or dogs. Transmission is through the bite of that infected tick.
Key terms.
Myalgia, muscle pain. Petechial rash, those pinpoint red purple spots from bleeding under the skin. Box 37-3 in the source talks about tick bite prevention.
What are the symptoms of RMSF?
Often start suddenly with fever, feeling unwell, loss of appetite, vomiting, headache, and severe myalgia muscle aches. The characteristic rash usually appears a few days after the fever starts, often on wrists and ankles first.
Yeah.
It starts as maculopapular, then spreads, often including palms and soles. Over time, it becomes petechial as blood vessels leak.
How's it treated?
This is serious. It needs prompt treatment with antibiotics, usually doxycycline. Delay can be fatal. Supportive care is vital. Monitor vital signs, manage fever and pain, watch the rash, and crucial. Educate about tick bite prevention repellents, protective clothing, tick checks, proper removal.
Right, let's shift focus now to something specific. Community-associated methicillin-resistant Staphylococcus aureus, or CAMRSA.
Right. So Staphylococcus aureus, or staph, is a common bacteria. Lots of people carry it on their skin or in their nose without any issue. That's called colonization. But if it gets into a cut, it can cause infection.
And MRSA.
MRSA is a strain of staph that's resistant to methicillin and related antibiotics, making it harder to treat. Historically, we saw it mostly in hospitals, hospital-acquired MRSA. CAMRSA is MRSA infection in people outside of healthcare settings.
Who's at higher risk for CAMRSA?
Certain groups. Athletes sharing equipment, people in prisons, daycare kids, military recruits, IV drug users, people in crowded living conditions, those with poor hygiene, sharing personal items like towels or razors, getting non-sterile tattoos, piercings, or people with weakened immune systems.
How does it spread?
Usually person-to-person contact, touching contaminated items, or infecting an existing cut or wound. And if it gets into the bloodstream, it can cause really serious problems. Sepsis, cellulitis, endocarditis, heart lining infection, bone infections. It can be life-threatening.
Sounds serious.
Yeah.
What are the best ways to prevent it?
Good hygiene is paramount. Frequent, thorough hand-washing soap and water at least 20 seconds. Keep skin clean and dry. Don't share personal items, towels, razors, clothes, sports gear. Clean shared equipment regularly. Clean any cuts or scrapes well and keep them covered until healed. And don't touch other people's wounds or bandages.
What signs might indicate a CAMRSA infection?
Look for signs of skin infection. Redness, swelling, warmth, pus or drainage, pain, maybe a fever. If it's more serious, systemic, symptoms could include chest pain, cough, fatigue, chills, headache, muscle aches, shortness of breath, maybe a rash. If a skin infection looks like it's getting worse or you have systemic symptoms, definitely seek medical attention.
How do doctors treat it?
They'll examine any skin lesions. Often they'll need to drain abscesses and take samples from the wound, blood, sputum, urine for culture to confirm it's MRSA and see which antibiotics will work. Then they'll prescribe the appropriate antibiotic, maybe oral or IV, depending on severity. Education is vital to explaining the cause, spread, symptoms, importance of finishing antibiotics, and prevention.
Okay, let's tackle another common one. Influenza, the flu.
Influenza, highly contagious respiratory virus, affects the nose, throat, lungs. Different strains circulate each year, hence the need for annual vaccines. Some groups are high risk for complications. Young kids, pregnant women, older adults, people with chronic conditions or weak immune systems.
How's it spread?
Easily through respiratory droplets, coughing, sneezing, talking. Also by touching contaminated surfaces, then touching your own mouth, nose, or eyes.
What are the key prevention strategies?
Number 1, the annual flu vaccine. It's the best defense. Then, frequent hand washing. Teach kids properly. Avoid close contact with sick people. Practice respiratory etiquette, cover coughs and sneezes. And keep sick kids home from school or daycare until they're fever-free for 24 hours without fever-reducing meds. The CDC website is a great resource for more info. Remember, typical flu lasts about a week. Longer might mean complications.
What symptoms suggest influenza?
Usually a sudden onset. High fever, headache, body aches, significant fatigue, chills, dry cough, congestion or runny nose, sore throat, loss of appetite. Sometimes vomiting and diarrhea, especially in kids.
How is it managed from a nursing perspective?
Antivirals like Tamiflu might be prescribed, especially if started within 48 hours. But mostly it's supportive care. Rest, lots of fluids to prevent dehydration, over-the-counter meds like acetaminophen or ibuprofen for fever and aches. Saline drops for stuffy noses can help. And reinforcing prevention teaching is key to stop it spreading further.
Now, underpinning prevention for many of these diseases is immunization. Saunders has a big section on this.
Absolutely. The Priority Nursing Actions box outlines the steps for giving a vaccine injection. First and foremost, verify the prescription, correct vaccine dose, route.
Okay.
Next, get a thorough immunization history, previous shots, allergies, any past reactions. Then provide info to parents, guardians about the vaccine benefits, risks, and get informed consent. Then check the vaccine lot number and expiration date. Choose the right injection site based on age and vaccine. Administer it correctly, intramuscular or subcutaneous. Document everything meticulously. Date, time, vaccine name, manufacturer, lot number, site, route, who gave it, and give the parents an updated record. Verifying the order and getting the history are the absolute first steps.
And general guidelines.
Primary shots usually start at birth in the U.S. If doses are missed, you usually don't restart the series, just catch up. You can often give multiple recommended vaccines at the same visit if needed, just in different sites.
When should a vaccine not be given, or given cautiously?
A definite no-go, a contraindication, is a history of severe allergic reaction, anaphylaxis to a previous dose or a vaccine component. Live virus vaccines, like MMR, varicella, are generally avoided in severely immunocompromised people, those with severe gelatin allergy, and pregnant women. Use caution if someone has a moderate or severe acute illness with or without fever. Minor colds usually aren't a reason to delay, and preterm infants get full doses based on their chronological age.
Box 37-4 has specific administration guidelines. What are the highlights?
Always follow the manufacturer's instructions: route, storage, reconstitution. Refrigerate vaccines properly, usually center shelf. Provide the vaccine information statement, VIS, and get consent. Check expiration dates. Use separate syringes and different sites for multiple shots.
Preferred sites.
For IM shots in infants, young kids, the vastus lateralis muscle in the thigh is preferred. Ventrogluteal, hip, is another option. Deltoid upper arm for kids 3 years and older with enough muscle. Subcutaneous shots go into fatty tissue, upper arms, anterior thighs. Use the right needle length gauge.
What about side effects?
Tell parents about mild local reactions. Fever, soreness, swelling, redness. Topical anesthetic might help with pain. Cool compresses first 24 hours for sore sites, then warm or cool. Acetaminophen, ibuprofen for discomfort if needed. Keep detailed records. And know how to report significant adverse reactions via VA or S.
Box 37-5 shows the 2017 schedule. Can you give a quick overview?
Sure. Hep starts at birth, then 1 in 6 months. At 2, 4, 6 months, common ones are ITV, polio, DTaP, Hib, PCV, pneumococcal, RV, rotavirus. Around 12-15 months, Hib booster, PCV booster, MMR, first HEPA, varicella, chickenpox. Second HEPA, 6-18 months later, 4-6 years. Boosters for DTaP, ITV, MMR, varicella, 11-12 years. Tdap booster, MCV4, meningococcal, HPV series, plus the annual flu shot from 6 months on. But critically, schedules update yearly. Always check the current CDC recommendations.
What kinds of reactions can happen after a vaccine?
Mostly local reactions: tenderness, redness, swelling at the site, maybe low-grade fever, fussiness, eating less. Using the right needle length and site helps minimize these.
And the serious ones?
Anaphylaxis, severe allergic reaction, is very rare but serious. Goals are secure airway, restore circulation, prevent more antigen exposure. Mild reactions might get antihistamine and epinephrine. Moderate severe needs immediate airway management, maybe CPR, epinephrine, fluids. Close monitoring is essential.
The source includes a critical thinking scenario about a child admitted with mumps and how to prevent transmission. What's the answer?
Institute airborne droplet and contact precautions immediately. That means a negative pressure room if possible, N95 respirators for staff, gowns, gloves, strict hand hygiene. Mumps spreads through droplets and direct contact, so you need all those layers of protection.
Okay, finally, let's touch on the practice questions. They reinforce key points, like question 376 on rubeola measles precautions.
Right, needing contact and airborne precautions because of how measles spread.
377 asking about mumps.
Correctly identifying it as a viral respiratory disease affecting the parotid glands.
378 on managing a local reaction to DTaP.
Applying an ice pack is the appropriate advice.
379 asking for a characteristic sign of scarlet fever.
Pastillas sign those red lines in skin folds.
380 on home care for mono.
Crucially, warning parents to report abdominal or shoulder pain because of the risk of splenic rupture.
381 about a characteristic finding in chickenpox.
That progression from macules on the trunk scalp to vesicles?
382 finding the flaw in parental understanding of flu prevention.
Realizing a child with flu is still contagious, even if taking acetaminophen, and shouldn't be playing with others.
383 identifying incorrect advice for tick prevention.
Correcting the idea that dark clothing is better, light clothing makes ticks easier to spot.
394 an appropriate home care for a child with AIDS.
Emphasizing hand washing, avoiding sick contacts, and proper cleaning of spills, but noting kissing on the mouth isn't advised and fever malaise aren't expected.
And 385, finding the misunderstanding about pertussis.
Correcting the statement that it's caused by a virus, it's bacterial. These questions really help solidify the information.
Exactly. They cover the nursing concepts, assessment procedures, safety, priority actions for all these diseases, plus HIV and immunizations that we've gone over. Well, that was definitely a deep dive. We covered a huge amount today: specific diseases, HIV, AIDS in kids, MRSA, flu, and the whole world of immunizations, from guidelines to reactions, all based on the Saunders Review.
hmm The aim was to give you a clear, solid understanding of this really important area of healthcare. We hit the key concepts: assessment, procedures, safety, priority actions, and those review questions. Tried to define the jargon as we went.
Right. So you should have a good overview now. As a final thought, maybe consider how quickly things like immunization schedules evolve, or the ongoing challenge of preventing new infectious diseases in our connected world. Always worth staying updated.
Absolutely. Constant learning is key in healthcare.
This deep dive has provided a comprehensive overview of the entire chapter on infectious and communicable diseases from Saunders Comprehensive Review for the NCLEX-PN Examination, 7th Ed, covering all key nursing concepts, assessment guidelines, clinical procedures, safety protocols, priority actions, and review questions, while clearly defining medical terminology as encountered.